Welcome, everyone. I'm Stefan Swartling-Peterson. On behalf of the Karolinska Institute and Makerere University, my co-organizer, Roda Wanjense, please be very welcome to this session. We are joined by my brother and friend, journalist, entrepreneur, medical doctor, chief of AMREF, Gitinji Gitahi, and my good friend, head of WHO's and the world's International Agency for Research on Cancer. And Roda, as you may know, is Dean of the School of Public Health at Makerere University. Myself, I'm a professor at Karolinska Institute in Sweden. We will be joined during this call also by Ricardo Baptista Leite, who will run in from his other session and sit down next to Roda. That's why we're not being unfair to Roda, putting her all alone over there. Feel free in this hot environment to take off your jackets, as I did, and we shall open the door when half the audience has suffocated. Okay, we wanted to talk today, and oh yes, here. Sorry, you're there. Precision prevention of non-communicable diseases. And what do we mean by that as we got together and wrote this abstract a couple of months ago? Well, personally, I looked it up. I'm from Sweden. My life expectancy, I've looked it up, is 20 years as I stand here today. But my health expectancy is only 13 years. So that means, and statistically, I can expect to spend 7 years sick, or as a patient, one way or another, maybe as it were. The other element of that, though, is that there are more and more people like me who will become 80 plus. And by the time I become 80 plus, there will be, in relative terms, twice as many 80-plussers in Sweden as there are now. And that is true for most European countries as well, that we are aging both in absolute and relative terms. Now, we are already in Sweden spending $7,500 per capita on healthcare. And obviously, to take care of me and all my peers, we will have to raise more taxes and more money. But even a more critical constraint will be that it will take the entire age cohort of people entering the job market to take care of me and my peers when we're 80 plus. Healthcare and social care is going to absorb all the health workforce. So unless, and we can think about migration and other things, but obviously for this session, the imperative is the one of health promotion and prevention and not becoming a patient. Now, Michael, if I can have my slide. There's only one slide today. Because in my expected 7 years as a patient, maybe I will experience precision medicine over here. I will be sick, someone will look after my tumor, and Elisabeth here will send me the exactly right treatment for my cancer, right? Maybe it will extend to other diseases. But I don't want to be a patient, right? And I want to be a citizen. So I want to be over here. I want us to prevent. I want to health promotion, making it fun to do the right thing and easy. And I need prevention, right? And the question is, how can we move our interventions across here? I think we have a demographic imperative for the Swedens and Europes of this world to do that. We have a precision medicine approach here. And when I meet my colleagues in the Prophet Consortium here, European Union, we're writing a research and innovation agenda for precision in prevention. It's full of geneticists, and they are very interesting people. They say, let's do whole genome sequencing, and we shall solve prevention. And I trained in social medicine, so I'm slightly skeptic, and then we have interesting arguments. And I say, for the first think there are other omics than genomics. But then there's also what is now known as lifestyle, which is often coined as an individual responsibility, right? And there is more data now in my phone, with my grocery company, with my internet provider, than I can meaningfully use in any way to adjust my lifestyle. And my point is that it's not just lifestyle and my choice, it's life condition all the way up there, right? What is my neighborhood like where I live? What is the food environment? And thank you to the Academic Alliance and the organizers, we had a good and healthy food environment for lunch now, right? But if they had served other food, I would have eaten it, right? And similarly, if there is a lift, I take it, etc. So the food environment, the physical environment, and the social environment. Famously in Stockholm, the red subway line between the two extremes stations, there's a life expectancy difference of 7 years. And I don't think that difference is genetic. So, without further ado, the issue was then to think about how we can move left in this paradigm here. Can we employ some of the precision tools for a precision dividend for me as an individual, so I can stay a citizen and not become a patient, but also for my society not to collapse, right? And we've invited a friend from Africa here, Githinje Gitahi. That's sort of a Swedish and a European setting, and why we obviously need to do promotion and prevention, and maybe not just blaming me for making the wrong choices, but also thinking about the environment I live in. What does that look like in an African context now?
Could I use that actually? Oh. It's because these people here are struggling. I don't know which one works. Hello? No? Mm-mm. Hello? It works. Thank you. Good afternoon, everybody. My friend here, Safan, has invited me to tell you something you know about. Nothing new. A stitch in time saves 9, and prevention is better than cure, isn't it? Yeah. I think that's the end of the keynote address. Thank you very much. So let's entertain ourselves now, because we already covered the topic. And I just want to very quickly narrate what my thoughts are and what my experiences are. The first thing I want to ask each one of you is, if you walked today into a village and you met the chief of the village with about 200,000 people, and this village is somewhere in Wakanda, in a country that you may not know, but most likely probably in Africa, and you wanted to know the health condition of the people, what would you ask the chief between the following two questions? Question number 1, how many hospital beds and nurses do you have per 1,000 people? Question 1. Or question 2, how many toilets or water taps do you have per 1,000 people? So between these two questions per 1,000 people, let me see how many would want to know from the chief how many hospital beds and nurses are available to the 200,000 people in his community or her community. Yes? No? Raise up your hand. How many would want to know how many toilets and water taps there are? All right. That's the dichotomy between health and healthcare. And I think the conversation that we are being asked to look at is the difference between health and healthcare. Where healthcare is something we consume. And if you look at the WHO health system building block, which I have often told him that it should be rebranded to healthcare system building blocks, not health, because health is not something that is supply side. Health is something that's intrinsic, as has been shown here. And therefore, if you are to think about the health of the community that you're talking to the chief about, you want to know how healthy that population is, not how they consume healthcare, which is more the supply side and the way we have detailed the building blocks of the health care, in brackets, system, because that's not the way it's defined currently. So where am I going with this? I am number 8 in a family of 9. My mother is turning 90 this December. How old are you now? You said you're 20. Yeah, okay. So my mother is turning 90 in Kenya, in a country, of course, whose life expectancy at birth is 67. And I'm sure when she was born, it was far much lower. But she is where she is, 9 children later. She delivered all her 9 children, including me as the 8th, normally. All of them are alive. And that was before the advances in genomic sequencing and all these things that we saw here. So my mother survived with 9 siblings who are still alive today. My eldest brother is 73. Now, we all escaped the burden of communicable diseases, maternal, neonatal, and nutritional problems, the communicable, neonatal, maternal, and nutrition. But we know that the burden on non-communicable diseases is now starting to affect us. As we speak today, my eldest brother, is admitted in a hospital with chronic renal failure, secondary to diabetes. Now, that example I'm giving you, with his permission, is to say that out of all of us, probably save out of anything that could happen, like an accident or something, out of the 9 siblings, the biggest risk as we speak today from my country in Kenya, out of our 9 siblings, is actually non-communicable disease. It's actually chronic renal failure secondary to diabetes. So where am I going with this? In the last 2 months, the family has spent about $40,000 to take care of my brother. $40,000. Now, let me then come down to the bigger conversation that I want to leave you here with. That if you look at what was said earlier about Sweden and the per capita expenditure on health, public resources only, maybe I'll make it $5,000, public resources, or what we call general public government expenditure on health, you would put Europe generally, which is now struggling with, of course, other challenges of aging and all these other things, which is not a modifiable risk. Age is not a modifiable risk, the last time I checked. But in Africa, we are spending of general government expenditure about $40, $50 per capita. 40 versus 50. Now, is it for failure of allocating money? No. It is because we have a demographic and economic crisis. So I do not think that there is any amount of Abuja Declaration advocacy or advocacy for more financing that is going to change the government expenditure in sub-Saharan Africa to more than $50 in the next 50 years. Which means that in a situation in Africa where, within the map that was shown here, where we have a significant burden already still of communicable, maternal, neonatal, and nutritional burden, we now have a rising wave of non-communicable diseases that's now impacting us, each of us in the families. And that burden of the earlier one, the communicable, maternal, neonatal, and nutrition, has been funded largely by the development sector, significantly. Though, of course, with a significant contribution from the government, because it is the health workers, it's the facilities that the government provide that give the foundation for the partners to put in their money for improving maternal and child health and other things. If there were no health workers, if there were no health facilities, Gavi would not succeed, irrespective of how many volumes of vaccines they will bring. So you must always recognize that what the government provides is the basis for international partnerships and local partnerships and regional partnerships. But that now is disappearing. We know. We don't have to go back to how much money is being lost in that sector and the health workers and the facilities will stay, but the international partnerships that deliver the public goods that then manage this burden of the communicable maternal neonatal nutrition, that money is going away. But as that money goes away, this other side of the non-communicable disease is rising. Right now, in many countries in Africa, 37% of all deaths is non-communicable diseases, cardiovascular and cancer. 50% of all admissions in the hospital where my brother is today is actually non-communicable diseases. But that side is actually not paid for by the international partnerships, nor is it paid for by the general government expenditure. It is paid for out of pocket. It's individuals that pay for it. So what I'm talking about here is this transition that I am afraid of, and we must be afraid of, that other than looking at the development, the communicable diseases, looking at non-communicable, we know that with the numbers I've given you of the money available for the public, for the sector, for the health sector, that with the rise in non-communicable diseases, there's only one result: a collapse of the health system. That's the only result I see, and that's not long. That's going to be in the next 20, 30 years. The health system is going to collapse. And the only way we can avoid the health system from collapsing is to shift our mindset from health as something we consume, which is the thing of you wait for disease, and then you get precision care, and you go in and you have all these dialysis and everything else, because we can't afford it. And the headliner here is that in my own continent, we cannot afford health care. But what if we said we want to, with a limited amount of money, we want to actually build health production? And health production means precision prevention. It means focusing on those things that actually avoid future costs. In my own analysis, implementing those precision prevention strategies, including basic ones: vaccination, water and sanitation, nutrition, better maternal and child health, all those things can bring down the cost of healthcare by up to 30%. In a place where you don't have adequate money, 30% is significant. You're talking about $30, $40 per individual, which then you can put into better response and better care. So my word here is to say that we need to reorient the health system to health production so that we are producing health, not consuming health care. And if we are producing health, it means therefore that we are shifting the blame from the individual to the policy, because this is the biggest challenge we have, is actually policy. And I like to say that the individuals are actually being mated on structural violence because they have inadequate policy. And I'll give you 2 or 3 and I sit down. The first thing is that we know that cervical cancer is not only preventable, but eliminatable. True? Vaccines for HPV are available in most of the countries that we work in Africa for free. But in many countries, the penetration or the access to vaccines for under 15 young girls is only 16%. So the challenge is not a resource challenge. It's actually a policy challenge. The next one is to talk about the issue about diet. We know that fast food companies that operate in high-income areas have found a new market in Africa, a huge market, and therefore they have shifted there. But their model of business is lowest denominator, meaning that if there are no regulations on front of pack labeling, if there are no regulations on sugar and salt, if there are no regulations on industrial trans fats, I will start there. Meaning that in the continent of Africa, all the fast food movement is coming at the lowest level of regulation, and therefore putting millions and hundreds of millions of people at risk of future NCDs. And yet, that's not an individual failure. That's a government failure. Because if you just look at the industrial trans fats only, you will know that WHO has guidelines, policy guidelines on how government should regulate industrial trans fats, especially in the fast food industry. Only 2 countries in the continent of Africa have implemented these guidelines. So it is not for absence of knowledge and information. It's policy failure. The last one is just environmental and urban planning failure, which is a policy issue. If you go to Kigali today, and we go there many times, you can walk at any time you want. You can walk to work and walk from work, meaning you don't have to be sedentary and take public transport or your car to every place you go. But if you go to Lagos or Nairobi or Kampala, where you have spent quite a bit amount of your time and where my sister Rhoda comes from, you will be warned against walking to work or walking from work, because you'll be risking your life, which is also a modifiable risk to your life, which is violence. So urban planning and all the other modifiable risks I've talked about are within the policy environment of the government. And this is why I conclude by saying that the policy holders are actually more dangerous than those who hold guns in their hands. Thank you.
Thank you, Githinji. That was powerful. Lovely. And we welcome Ricardo Baptista later. Thank you for coming. You're much in demand, so you come from another session. You are a CEO of Health AI, right?
Correct.
Correct. Which, I looked this up. There is a hyphen. It says the Global Agency for Responsible Artificial Intelligence in Health, right? So we look forward to hearing from you in a bit. But first, Elisabetta Weiderpass. I mean, you head up the International Agency for Research on Cancer. And sort of precision medicine really comes from cancer care, doesn't it? Yes. So, but now that you're responsible for all of cancer in the world and for research, how does this extend now into prevention? Is there a precision dividend coming?
Thank you very much. Can you hear me well? Yes. Thank you so much, Stefan. It's really an honor and a pleasure to be here amongst friends. And it seems that there is consensus in the room, so that gives us much more freedom, as my colleague already said. Indeed, so precision medicine, a lot of it is based on the cancer field. Why? Because it has been shown that unlike one-size-fits-all for cancer therapy, treating patients based on their genetic profile or in the tumor genetic profile, as well as in other omics, or treating patients that have precancerous lesions quite early, you obtain much better results. And this has been shown for several cancer forms. I cite melanoma. The prognosis of melanoma has completely changed in the past decade or so for being a highly fatal disease, for being a chronic disease. Lung cancer, we are going the same way. Several forms of colorectal cancer. Breast cancer, survival of breast cancer in most Western countries is over 80% for 5-year survival. In other parts of the world, it's still less than 30%, as in Sub-Saharan Africa, and so on and so forth. So this is the powerful combination of genotyping, as Stefan was alluded before, characteristics of the patient, characteristics of the tumor, and then tailoring drugs, which are very specific for each different disease. So that's the concept of precision medicine within cancer care. So it's based on data about the patient or the disease, in this case, the tumor, and it's based on clinical trials that are not traditional. These clinical trials that reach the conclusions about these innovative treatments, usually they are smaller in usual chemotherapy, let's say clinical trials. They are faster to implement, and their outcomes, it's really based on character biomarkers. It's not really mortality, or in many cases it's not mortality or overall survival, but it's based on biomarkers of tumor progression. So key components, the genetic profiling and the surrogate endpoint, which is not survival, is usually biomarkers. This approach raises lots of questions. Equity is the first one. So who has access to genotyping, to these very expensive drugs? So each of these drugs can cost easily $1 million per year. Which institutes have the capacity to recruit these patients, diagnose them, screen them, put them on treatment, and offer all the needed follow-up? There are lots of regulatory challenges. I mean, which countries have the regulatory capacity to evaluate and approve and eventually pay for these new drugs, and so on and so forth. So lots of questions on equity. And of course, I'm sure you are all familiar with the best buys of the WHO. None of these new treatments is included in the best buys because of cost effectiveness issues, and we all can question how cost effectiveness is calculated for the best buys, but in a nutshell, they are just too expensive as we speak today. And also we have, as you all know, the quick buys from WHO, which are the best buys, but that will give a return for investment, let's say, within 5 years, which is the lifetime of a politician in power in the best case scenario, and they are not included there as well. So now what Stefan is proposing us is to take these concepts of precision medicine in care, in cancer care, in my case, to prevention and early detection, because they go hand in hand, prevention and early detection in cancer. Because although we can prevent up to half of all tumors, half of all the other tumors we cannot prevent, but we can, to some extent, detect them early. And this makes a difference between life and death in most cases. So prevention. When we talk about prevention, as you alluded, with other words, we are talking about what I would call primordial prevention. That means the prevention that's above our heads, is regulation, is legislation, is control, and making sure that the legislation and rules are followed, and if they are not followed, which are the consequences. And I fully agree with you. I think there needs to be much more awareness and work in that sense. Then we are talking about primary prevention. That means that things that are at least partially into the power of the individual or the families or the citizens to act. And here we can list, for example, while making HPV vaccination available for free, let's say, it's a policy that can be taken at primordial level. It needs to still be the family that gives the consent for a child to be vaccinated. There are several other examples. Obesity, for example, you can regulate the selling of junk food in schools, for example, but unless you have the families also adhering to that, is not to have full effect. Then we are talking about secondary prevention, and here, specifically for cancer, there is a very large, which is already being implemented in several countries, component of precision prevention. So secondary prevention for cancer is basically screening and early detection. For screening, we are talking for most countries in the world, at least for cervical cancer. You alluded already, HPV vaccination is primary prevention. HPV detection in the cervix is secondary prevention, and that can be done, for example, in a different way for women which are HPV vaccinated or not, or women that have had precancerous lesions or not. We are talking about breast cancer, target prevention for women that have a higher risk based, for example, on family story, on the age when they had the first child, because that has an influence on their risk of breast cancer, how many children they have had, and other characteristics. We are talking about colorectal cancer prevention. Again, family story, age, sex, type of diet, and so on and so forth. Prostate cancer and lung cancer, although WHO and IARC does not recommend yet population-based implementation, there are studies, pilot studies ongoing, indicated that very soon we will be able to make recommendations for at least for specific subgroups of the population. And then we talk about, of course, tertiary prevention, survival. And here also I would like to talk about that, because it is very important. In most countries now, the sheer number of cancer survival, and by cancer survival, I mean a person that has had the diagnosis of cancer beyond 5 years, so the person has survived up to 5 years, it's a very important group of people. It can represent up to 30% of a population in some countries. It's massive. And these people do require some attention. And some measures, for example, smoke cessation in patients with cancers or in survivor patients, can have even a higher effect than some uses of chemotherapy or other therapies. So this all is feasible, is affordable, and the return of investment it pays off tremendously. And this is all proven and documented. The question is implementing it. What needs to be done? Needs to be data-driven, of course. I think with what has helped and many countries in implementing this is they say, well, we don't see the return of investment, we cannot demonstrate how we can convince, how we can invest for that. And I think, this community, which is a very informed community, can help with that, provide data, supply data indicating that the costs, for example, that your brother is incurring are just unaffordable at population level, and that this precision prevention in subgroups of the population more adapted to risks can be implemented at all levels. Which countries are doing that? And which countries are having that effectively implemented? Several. I can cite Australia. Australia is doing that in a magnificent way at all levels of prevention. There are several European countries, and within Europe, since I have more than one colleague here speaking about Africa, I just want to give an example of Europe, where there are two major initiatives in the past 6 years or so. One is the European Beating Cancer Plan, where the mindship has shifted from targeting specific areas of cancer action to a more overarching view from prevention until palliative care, and also the European Cancer Mission, where again we are trying to provide evidence, written evidence of the impact of the different types of precision prevention within the European country. And we have a very large portfolio of research going on in this area. Implementation is absolutely key. So just to plan a prevention strategy does not save lives. Of course, implementation is what many countries struggle, because it's much easier to implement measures for everyone the same, but the impact is much less. So implementation and research on implementation and how we can target pockets of the population which have special needs is where I think the community is really, it needs to be, there's an opportunity to do more and do better. In terms of costs, just to reinforce what my neighbor has already said, I was in Mexico 2 weeks ago, and I had the privilege to meet the minister. I believe he's not participating in this meeting this weekend. But what I was informed is that for the overarching budget of the Ministry of Health per year, over 30% is being used in cancer therapy. This is not sustainable. It's simply not sustainable. And each year, the amounts are growing. So unless we do, as you both already suggested, that we shift the focus on prevention, the cancer needs will make ministries of health budget collapse entirely. I would say within the next 5 to 10 years, because the amount of new drugs that are being discovered, luckily, is huge, and they are powerful, and they are very interesting. But are they affordable? And the answer for most countries is they are not. How are we going to pay for these drugs? Big question. There are two ways, basically. Taxation is insurance, and then there is out-of-pocket. But out-of-pocket, it will be unaffordable as well, I think, for most families, if not all families in the world. So we need to rethink the whole system because of the advanced, and in particular with the help of AI now, more and more innovative drugs will be put into the market, and that's fantastic. But the whole system needs to be thought about. So again, in short, it is possible, it's feasible, it needs to be done. It needs to be done as early as possible at all levels of prevention. Primordial prevention, primary prevention, secondary and tertiary. Target specific groups of population that have special needs.
Elisabeth, would you say that the research portfolio is balanced across that spectrum?
No, absolutely not. So if you look at the amount of money dedicated to NCD, let's say within WHO, it's couple of percentage, 2%, I think, of the overall budget. So everything else is infectious disease. Infectious disease do cause non-communicable diseases, for example, some types of cancer. But I mean, there is very little investment in non-communicable disease as a whole. And within non-communicable disease, and I will talk about cancer because that's what I know about, the investment on prevention is less than 5%. So over 90% is investment in new therapies, innovative therapies, drugs, which we all need. But there is a total imbalance in terms of investment in discovery science / therapies, in particularly chemotherapies and innovative therapies, vis-a-vis prevention research. Yeah.
Thank you. Ricardo, before you came in, there was an allusion to sort of 5-year survival of politicians. But I think you survived as a politician more than 5 years. but now you've shifted to handling data and AI, right? And we hear great hopes about data. And I'm sure there are a few megabytes worth of data about me somewhere out there. I can't make sense of it. Can you make sense of it and help me as an individual and help my neighborhood and help my part of society?
Thanks, Stefan. And there are terabytes of data associated to you, I can assure you. And yes, I was in Parliament for 4 terms, and was also in local government as a deputy mayor and city councillor. And I left before they kicked me out, so I guess that's the trick to surviving. And it's an exciting time, of course. And every discussion now ends up, of course, talking about artificial intelligence, its potential. Listen, if data could save the problems of the world, we would have solved them by now, because there's so much data out there. It's transforming data into information and information into policies and into clinical decisions and actions. That's what is critical. But you know, I am the CEO of Health AI, which, as you mentioned, is the global agency for responsible AI and health, a nonprofit out of Geneva, working with governments to provide capacity strengthening so that countries are more capable of governing artificial intelligence for their health systems and to scale AI technologies within their health systems to improve health outputs. And the most frequent question, the most frequent thing we hear from people, of our counterparts around the world is, they come to us and they say, we want to use AI, right? And so I always like to ask, why do you want to use artificial intelligence? And the most common answer I get is because their boss is telling them that they have to do something with AI, or it's their board is telling them, or their minister now believes that AI is going to solve the problems of the world. That's not how it works. We need to be intentional on the way we use the technology. The technology will not save us from all of our problems. We need to know what the hell we want to do with the technology first. And the truth is, as was mentioned, we have a broken health system across the globe. Mm-hmm. We shouldn't even call it health systems. These are disease systems. They are reactive to disease. And so without fixing that, the sustainability issue that was mentioned on the focus on cancer, but it is horizontal to every sector of health systems around the world. And so we need to make sure that we want to transform the system and that we understand that we want to shift towards prevention, to quality of life and well-being, as the main outputs we want to achieve with these models of care that we are developing. Putting prevention, and that's why I think this session is so important, because you put prevention in the title. And it's not just a side gig for health system, which is what happens normally. And understanding that without doing that, we won't be able to provoke the change. But if you have leaders who understand that this is the way to go, then you can say, okay, how can technology help us get there? And if we have that mindset in place, there is hope. Because when, I believe you showed that slide, I wasn't here at the beginning, but we spoke before, you had that slide with the different bubbles. So if you think about that translated into data, 10% of what affects our health as individuals, each of us, are clinical factors. As a physician, when I have a patient in front of me, I'm looking at 10% typically of what truly impacts that person's health. 30% of what impacts that person's health are the genomic and biological factors that we can tweak around with technology, but we still have a long way to go. 60% of what affects our health are exogenous factors, where we live, where we breathe, the choices we make, if we decided to have that healthy vegetarian lunch or if we went outside to Burger King, right? these are the things that will affect our health in the long run. And all of these factors represents terabytes of data that we have never been able to translate into the policies, into the clinical decisions. And that is where I believe the greatest hope of artificial intelligence truly lies. And if you think about now the personalized and the precision approach to this, we understand that today we can have the ambition of identifying phenomena through predictive analytics before others identify it, even ourselves. We should proactively identify people who are at higher risk before they get sick. It's not just about early diagnosis, it's about prevention altogether, primary prevention altogether. But of course, there are situations we're going to miss, and secondary prevention is going to be important. And making sure that then, after people are diagnosed, they stay on treatment if necessary, that we can make sure that they have the proper follow-up. And understanding that we can help people also in terms of the other components of health systems that are less visible but extremely important, from managing waiting lists to managing all of the financials and the navigating within a health system, which on an individual level is so difficult sometimes. People are absolutely lost. And so today, even with the power of virtual assistants, for example, being able to reach out to people and have that kind of personalized approach is incredibly important. And actually, sometimes we've seen in comparative studies where doctors are compared to robots as assistants, the robots have produced better health outcomes. And in many cases, they've actually shown more empathy in accordance to surveys than humans. Let that sink in, right?
Ricardo, when you were a mayor, you were not just treating individuals, you were also treating communities, were you not?
Yeah, so I was going to get to that. And that's an important topic at the city level because, and I was just letting it sink in that that robots can actually be more empathetic and it's true. We as humans, we get hungry, we get thirsty, we get angry. Yeah. We don't have time for anything. We're running around as I am today. But then at the city level, as you were mentioning, the power of personalization is also critical. So actually, where I was deputy mayor in Cascais, near Lisbon, it was pre-LLM era, but we were already using big data. And what we did was we created a program called Smart Health, where we got all of the data we could on health, social affairs, and education, and we geo-referenced it at the parish level. And that started to give us interesting cross-linking data and phenomena that we couldn't identify otherwise. I remember a case where the European Union was funding the building of bike lanes within the city. And almost every mayor, when they get money to do that, they'll put the bike lanes in the nicest part of the city. In our case, that would be by the sea. And at the time we had a discussion, I said, why not use the data and have a data-driven approach to this decision? And we started by building the bike lanes where we saw the highest levels of childhood obesity and diabetes and so forth. And so it is possible to also think of precision prevention at the policy level. And I think this is incredibly important. Businesses are also having this approach, but this is also raising some challenges that we've discussed before. And this example really resonated with me as a potential negative impact also. And that's why Health AI is so focused on governance and responsible use of technology. There's this case in the US where a big retail chain of supermarkets, they would use AI predictive analytics to reach out to clients to let them know, of promotions, of things they believed that people would need even before they knew they needed. And there was a case where they sent a congratulatory letter to a person's home who was underage, 16 years old, congratulating her for being pregnant. Her dad got the letter, and she didn't know she was pregnant. And so the father sued this retail chain. And then it was proven that she was actually pregnant without knowing. And they found that out based on big data before she did. So this is just an example of how we have to be conscious of how all of this interconnects. But if you think of it the other way around, if we can detect people that are with a cardiovascular disease risk or cancer or whatnot, being able to proactively, or when we talk about vaccination, which policymakers today seem to be hesitant about, where it's truly a lifesaver, and proactively reach out to those that can benefit the most to bring them into the system, this approach is critical. But to say this, and I'll stop here, Stefan, for now, for this to work, for an idea of prevention to work, to go beyond our current model of disease-driven health systems, you need to align the incentives. The people managing health systems around the world typically are paid based on disease, the way they react to disease. There are not real incentives, and there are exceptions, but they're not money incentives towards leading to people getting healthier, to making sure if you're managing a region of health, and if you miraculously could cure everyone in your region, probably your Minister of Health will tell you, you don't need any more money. You don't have any sick people anymore, right? It's exactly the opposite of what we should be achieving. So we have to put in the incentives, but putting in the incentives have to be very careful, because policymakers always think that what they're doing is going to be positive. But sometimes the incentives are negative. Now, I'll end with this. I was having a Zoom call, and the guy on the other side, and he was in Asia, he had his phone on his desk on a swing, going back and forth. And I took that for 5 minutes, then I got fed up. And I said, sorry, man, why do you have your phone on a swing? And he said, oh, sorry, Ricardo, it's just because my insurance company gives me a premium if I do 10,000 steps a day. And so, so you have to be careful with the kind of incentives you put in there.
I think that's lovely. But we all use AI, right? Yesterday, I attended the prize ceremony for the Virchow Prize, right? And which was very impressive. And then I asked AI, who should I nominate for next year? And they actually mentioned your name, Ricardo. So maybe you fix that in the system somehow. Huh? But I'm inclined to do that, having listened to you now. Rhoda Wanyense, you're Dean of a School of Public Health. And public health is more than health care, isn't it? And health is... depends on many sectors. What do you make out of all of this?
So what do I make of all of this? And thank you, all of you, for starting this off in terms of the example of cancer care and also all the elaborate comments you've made about why it's important for us to shift to the left in terms of promotion, but also doing it using the example of precision, data, and analytics. I think this is really important because we need to know who is it that's likely to become ill from what, where are they, and what are the exposures, what is driving that. That's really important for us because you elaborately from your one slide, took us from the biological factors to the choices that we make, our lifestyle. But we have bigger issues around the environment that we live in where we have less leverage in terms of what others do. And what others do in that environment is going to lead to somebody becoming ill, and that's what brings in the common good and the broader policies and decisions to make sure that beyond the choices that you make, the choices that others make can also be regulated. I think that's really important. And I do appreciate the emphasis from Ricardo, the 60%, because I think that's where it really lies. Where are most of these exposures and how can we deal with them? Where is that data? When it comes to the environment, I know you said you're going to open here when some people have suffocated, but I think we are suffocating as we take walks in some cities without knowing. We just don't know what we are breathing in, how bad it is, and what's happening to us. The food that we eat. Just thinking back in my country, and I know the same is true probably in some of your countries, increasingly we're using lots of chemicals, pesticides, herbicides in the food that we eat, very unregulated. So what are you actually eating? Where is the data? And who knows what's happening to you? So you can make all the right choices, but something is not, okay with the food you eat, the water that you drink, the air that you breathe. So essentially, when we get to data, for us to be able to make more decisions around prevention of disease at individual level or with groups of individuals within the community, we need more data. And I think there's lots of issues there. I hope Ricardo can speak more to that as well. But being able to even just map out the most heavily populated spaces, whether it's exposures in food and what is going on, and making this data available, including being able to model and give us the real scenarios of what it's leading to in terms of disease, is often really good, especially when we are talking to politicians, because quite often they want us to give them a bit more bubbles in terms of what does this really mean and why should we intervene. And then there are products where they make money. I mean, we've been arguing a lot about alcohol in my country for a long time. After many years of doing the same with tobacco and then passing a bill, which we are not implementing. So we have all these things, you know, the incentives to the politicians is more money, but how do we also shift this so that we can really get to them a straight message? So there are issues of data. Of course, for the biological and genetics, that is really, really far away for us, Elizabeth, in many ways. If we are using it just so that we can study populations and we can apply it on a broader public health scale, I think that's really important. But so when I get to this, one of the points I'm trying to make is data. I think the biggest inequity we have is also data. For many people where we are and the things that are happening to us, nobody knows. You are not known, and what's happening to you, what you breathe and what you eat is not known. So we need to make this data that can drive decisions at the promotion and primary prevention level more accessible. In many countries, we haven't even done surveys around non-communicable diseases and to characterize the risk factors properly. So I think we've done only 2 of these in my country. Being able to characterize some of the risk factors and the trends in the risk factors and mapping out the populations that are most at risk so that we can be able to get to them. So data is going to be a big issue if we are going to apply the lessons of precision from cancer care to prevention. So we need to do so much around there. Now, moving on across the continuum, of course, there is also the early detection and management, but also all the various levels of care right up to rehabilitation. There's lots of data that can help us to learn a lot around the exposures, but also the progression of disease and many issues that we can apply to actually promotion as well as prevention. We need to do that as well. But the state of that data is actually not good. There's lots we can learn from laboratory data, from clinical data that we can apply to promotion. The state of that data is good. Primarily for most countries in Africa, data has previously focused more on infectious diseases, especially HIV. So when we look at electronic medical systems and how they were developed, in most countries they are focusing on HIV. And then you find the same facility with electronic HIV data, but with paper-based data that's poorly managed for non-communicable diseases. We don't have the privilege of using data well from those kinds of facilities. So we need to do more to protect and use that data better. So the quantity, the quality of that data, the connection between the clinical and laboratory data so that we can pull it together and tell a story about individuals is also complex. And then research, the research itself, in non-communicable diseases, because that's how we will generate the data and be able to move us to precision prevention for individuals. That is a challenge because most of the investments have been largely in infectious disease research, and the capacities for non-communicable diseases remain really, really limited. So we do have quite a number of things that we need to look at in terms of how to move us to the left towards the precision. Then the analytics, we actually have lots of data. It might not be the best, but we do have a lot of data. But the capacity to pull it together and make meaning out of it, as Ricardo said, is also part of the issue. So we need to invest more in the analytics with very targeted questions towards how we can be able to promote across, promote health, but also the prevention across the continuum. There are quite a number of equity issues, whether it's the data itself or the choices, access to information, and whether it's the issues of whether you have control or not in terms of policy and the environment that we live in. and many others that we probably need to deal with. But if we are going to move to precision prevention, I think the biggest issue is the data and equity in access to the right data to make those decisions.
Thanks. You know, thank you. That was the first round. And now we're good. We have 30 minutes for community interaction here, so get your question ready. But as we do that, you made me think of, we did a pre-diabetes project with people that looked like me, that had were a bit too fat and a bit too sedentary, and their blood pressure and their risk was a bit of this. And we compared South Africa, Uganda, and Sweden. And then it turned out that which health system was best equipped to deal with people like me? Well, the answer was not Sweden. Because, Githinji, both South Africa and Uganda had community health workers. And meanwhile, in Sweden, I have a GP whom I see once a year. So what's your take on community health workers and community action and taking people like me and moving me as a group with other peers?
Well, this is a fundamental question on what kind of health system we want to have. And I think the current health systems, which we say are not fit for purpose for the future, were built on a purely biomedical model. And this other thing that we call community health workers, task shifting, is always looked down upon because the biomedical trained professionals always want to push back on what they call health workers for poor people. Mm-hmm. And health workers for poor people is really saying, it's actually, I put a parallel between these and food for poor people and food for rich people, and health for poor people and health for rich people. I'll tell you what I mean by that. In most of Africa, when people get semi-urbanized, it is better for them to consume westernized foods. That is calorie-dense foods, fast food, and they feel they're feeding their families better because they can take them to a fast food and feel, now I'm a proud parent. I can buy burgers and pizza for my children. Now, on this side of health workforce, we need more of community health workers, but we feel like when you get community health workers, you're actually moving towards poor health services for the people, whereas it's actually the right health services. So what do I mean by this? The first thing to do in view of this conversation is to ask ourselves, where is health really made? Health is really made at home. Because as you said, majority of people, 90% of people are born healthy without any challenge. Therefore, the purpose of the health ministry, the health system, health policy should be to keep the people healthy. And that is the role of community health workers. Because the community health workers live with the communities, and they are the ones who know who is pregnant. Ricardo, the community health workers might know before big data, because the girl will stop going to school, she'll start not coming home and that kind of thing. So the community health workers know what's going on, and therefore they can actually go to a family and say, well, you just got a child and that child needs to go for vaccination. Or number two is that we have a problem with cholera around here. Could you actually check whether you're boiling your water properly? So community health workers are at the center of building health production. But they are not funded because the budgets are more about health consumption. This is the challenge, and therefore the reorienting of the health system we are trying to do is, if you actually reorient to health production, then community health workers will be the primary investment automatically by policy. So it's faster mind shift.
Lovely. Thank you. I'm sure we have someone who has a thought here. Oh, here's the gentleman. And now I'm going to do this terrible thing and hold the microphone.
Can you hold it for me?
Yes, I hold it for you, and if you talk too long, I take it back.
No. Just Casimiro Vizzini from the Africa Europe Foundation and UNESCO. It resonates a lot with what we are doing with the Human Cell Atlas. The Human Cell Atlas is an initiative that's quite known. It started in 2016 about research on single cells. And actually, there's the reason why they are collaborating with us is because Africa is lacking capacity. And also, as you mentioned, data, it's extremely important. UNESCO Open Data recommendation, Open Science recommendation on 2021 is not implemented efficiently. So we are trying also to combine this, and this was very important in terms of planetary health, with the Exposome Moonshot program. So having data combined with the cell data and exposome data. So how can we do that better for Africa? Because this is our goal.
Thank you. That's one. You'll keep this in mind. You have paper and pen if memory fails you, right? Lovely. Here's a lady. Who are you, madam?
So I'm Ojasvi Mahale. I'm a public health student at Charité University of Medicine, and I'm a medical doctor. So my question, first of all, thank you everyone for a wonderful session. The session focused on how we can use data for making better policies. I was thinking there's certain places where there's already enough data, for example, harmful effects of tobacco, for example, or alcohol, and we have not been able to incentivize policymakers into discouraging it so well. So what more can be done on this, since we already have enough data on it? So what else can we do?
Thank you. Sir.
Yeah. Thank you so much. One thing is...
Who are you, sir?
Okay. Cliff Richard Edekibo from Kampala, Uganda. Thank you for the presentations. In an environment where the speakers have mentioned about the policy framework and the healthcare system violence against the population in the dynamic population characteristics of today, what can these conversations translate into policy framework reforms at a higher level, especially those who are in charge of these policies? Thank you.
Wow, you're preparing for the presidential election.
Thank you. Thank you. My name is Mari Tikkanen, and I actually have a small observation and then a question, and it was to the cost. I would say I wanted to give a shout out actually to the Finnish government, who I'm a stage 3 cancer patient, and I've received 25 rounds of precision medicine chemotherapy, and it's cost me 143 euros. So just as a comparison, that was just a small observation. But my question is more that for precision prevention, what role do you see self-care playing that? Because we all carry out self-care acts, and in Europe alone, if we stopped doing self-care, we would need 120,000 more GPs at a cost of 34 billion a year, and our collective global self-care acts save 119 billion a year. And we haven't got a sort of system-integrated, system-provided self-care service or solution available today. But that, so my question is around that. Thank you.
Thank you. I'm being very democratic. We had 3 on this side. There'll be 3 on this side.
I can take here, and I can take the...
Hi. Thank you for the presentation. I just wanted to have one quick question. And considering that 1 in 6 individuals in the world live with a disability, how are you ensuring, being intentional in collecting data, that the outcomes of persons with disability are included, knowing that the AI also have biases on disability?
Yeah.
Excellent point. Let me go this side. And get ready. Sir.
Hello, everyone. I'm Titus Ndokero from the African Youth in Digital Health Network by Africa CDC. My question is about the community health workers. I grew up in Uganda, and I grew in the more urban areas. And in the urban areas, everybody lives within a fence. So I don't think the same kind of community health workers that work in villages where everybody is just able to meet each other more freely. So I was wondering, like, for example, from the digital health network, so is there a way of doing this through like telemedicine or through promotion on television and stuff like this? Is this the way to go for such a action, for example?
Lovely. So we had 3 plus 3 members. Rhoda, which one would you like to take?
Okay, excellent questions there. So the self-care question, I think for me, is such a critical piece in terms of reorienting the systems. And I know, Stefan, you like to talk a lot about systems for health, so that we are not talking health systems, but there's also self-care, taking in, care of both individuals and households and their communities, taking charge of their health. And this is so critical, both for promotion and all across all the levels of prevention up to rehabilitation. We know they also play a very critical role in terms of care after diagnosis as well as rehabilitation. So it's a very, very important component, especially because we shall never have enough health workers to take care of us. And there are certain aspects that they probably cannot do as well for us. So that's really important, and thank you for raising that, I think, Marion. And then I wanted to also touch on the issues of data and decision making. Yes, we need a lot of data and we have lots of gaps, but we have certain areas where we have sufficient data. I think we need to do more in terms of speaking for the data, the advocacy, and finding the right incentives for the policymakers and politicians to be able to take charge of some of these issues, and perhaps creatively thinking, and I hope we can have some ideas of how you can create a movement with incentives that can make politicians, I hope Ricardo can comment on that. What is it that would take when he was a mayor or when he was in other political spaces for us to actually be able to get them to act where we have enough data? But that said, we need to also generate more data around other areas, and we probably need to move that simultaneously. And that speaks for the issues around the open data. I think that's the comment around open data. We have lots of data, but who has access to it, and in what form is it? Is it even usable? Because if it's going to be open, but we don't manage it well, it's not archived well, it's not managed in a manner that you can make meaning of it, I think there's lots of issues. And this open data movement is one that we have all been keenly looking at in terms of how it can go beyond the policies to advocating for the systems and infrastructure that can help us to better harness the data that we already have. Yeah.
Thank you. Ricardo, I think I heard your name mentioned here.
Yes.
We all know which question we wanted to answer.
That was very nice to put me on the spot there, but I'll do my best. If I may, just before jumping to your challenge, just say, because I think it's an important question on disabilities, and I would also perhaps include other marginalized minorities. The truth is, data sets are today built on rich country data sets, and then also on generalized population, which means that people, be it disabilities or other subgroups, will be somewhat excluded if we are not intentional in the governance models to make sure that we are assessing the training of the AI models. And so it's an incredibly important point, and that's what we're also advocating for when we talk about the responsible use of AI and helping for regulators to have that capacity. Most regulators don't have the capacity to do that assessment, and it's incredibly important. The second topic that I'd like to address is on self-care, because technology, I think, can also play a very important role. And it's not technology that we're using in a way that we know we are using. It's actually, I believe, the breakthrough will happen when we start using the technology without even thinking we're using AI. So when we have to walk around in a city and we use Google Maps on our phone, we're not even thinking we're using of artificial intelligence. It's a very powerful AI tool. The same will apply to health. I come from Portugal, a rural hospital in Portugal. There was a lady there, 80 plus years old, who, after she was discharged from the hospital, they needed someone to keep following up, making sure she was doing her meds and doing everything she needed to do. She started getting daily calls on her phone. And it was a robot. And, a Portuguese elderly woman, she would speak for hours probably. And this was the reality. And no doctor would have that time. When she got to the next hospital visit a couple months later, she told the doctor, "Can I meet the assistant who's been calling me?" And they said, "Well, it's a robot." She says, "You know what? I don't care. She's just so kind. Just give her." So if we think about the power of technology to address, it can be transformative, I have no doubt. But going to Rhoda's challenge and to the questions there in the back, which is always the question we get, which is, and I founded a network called Unite. It's a network of parliamentarians in 120 countries around the world for global health. And we always get this question: how do we convince policymakers to change opinions. And it's getting harder, I must say, in this polarized world. And there are two answers to this. One, very quickly, and I can deep dive if you want, Stefan, which is policy calculators that we've developed at my university, which are apps where we allow you to play the role of Minister of Health. And so you can actually play different policy scenarios in your own country for different diseases, and it calculates the outputs. And so you as an advocate can use that to try to convince the policymaker. And you can check, we have one out for flu prevention, for example, that you can check at letscontrolflu.com. And so using that as an advocacy tool to convince a policymaker, because by using this, you're able to address what's going to happen, but you're allowing the policymaker to benefit from the future gains today. And so that leads me to what is the framework we use to try to convince policymakers to change? And we've come up with a 5-letter approach called ABCDE, the first 5 letters we learn in kindergarten. And it's A for awareness. If you're talking about something that the politician doesn't know about or their constituents are not pushing them for, nothing will happen. So you have to make sure that you're raising awareness, you know who you're talking to, and you actually are addressing the key issues for them and putting the agenda front and center, in a way that they will mobilize them for change. B is budget. We always say, as scientists, we tell the politicians, you have to do this, and you have to find the money. But actually, it's not that easy. Politicians will have 10 meetings on the day they're going to meet you. You have to come in with a plan. You have to say, this is going to save you money now. It's not about the future. Now. Or you don't have to spend more. Or if you have to spend more, I know where you can get the money because you're wasting it here and there. You have to come with a key in hand solution. If you do that, the politician may actually listen to you more carefully. C is cost of inaction, probably the most important letter. It's something we don't talk enough about, which is we're always saying what needs to happen. We don't talk enough about what will happen if you do nothing. And the truth is, doing nothing is a political choice with political consequences, with health outcomes, many times negative health outcomes. And so we need to make sure that that opportunity cost is very clear, making the case. And that leads us to D, which is data, to be able to create a foundation for everything that I've mentioned before. And E is the most cynical letter of all, because it's elections. Actually, we have elections in Portugal today. And these elections are incredibly important because telling a minister or a decision maker 1 month before an election what they need to do, they'll say yes to everything, but it won't change anything. You need to make sure that you are choosing the right timing and the right approach. You have to be political strategists. And that's a message I would end on, which is, as scientists, as leaders in the global health community, it's not enough to produce good evidence and science. We have to partner with those that can help us on the political strategizing, because what we do will only achieve impact if it is actually reaching the citizens and the patients around the world. Thank you.
Lovely. A, B, C, D, E. I think that's fun. I've even written it down now. I think it might. Lisa, which question would you like to address here?
Thank you. I will address Mari Tikkanen's question, if you allow me. So, Mari, thank you for sharing your experience. I think if I would ask people to raise hands if they are personally touched by cancer or their immediate family members are touched by cancer, probably 80 to 9% would raise their hands. So, and if we are in that position, we want healthcare now, immediately, as soon as possible. We want it of high quality, and we want it consistently throughout the period we have the challenge. And as we mentioned before, that healthcare in the best case scenario is subsidized by taxation. It's the case in Finland with Kela, where you paid €143 for 27 rounds of innovative therapy. That's not the cost of therapy. That's a small token to the system. But the system, the taxpayers haven't taken care. That's universal healthcare, and that we know saves lives big time. The 10% that he mentions, but that 10% is absolutely fundamental, in particular when we are touched about it. In terms of self-care for cancer survivors, the recommendations today for cancer survivors are the same as for non-cancer patients. in terms of diet, physical activity, non-smoking, non-use alcohol, no exposure to other carcinogens, etc., etc. So this evidence-based science today for cancer survivors is the same as for the general population, with very few exceptions. For example, people operated for gastrointestinal cancers, sometimes they have special dietary needs because they have a problem in absorption of nutrients and they lose weight very quickly. So there are specific recommendations for that. But self-care and care helped by primary healthcare workers, and I would go to the question of our other colleague there. Now I'm talking about cancer. 20 million new cases per year, 10 million deaths per year today. This is going to increase to 36 million by 2050 and 18 million deaths by 2050. So it's 70% increase in a nutshell. It's massive. It's massive. Most of that increase is due to the aging of population and to the sheer amount of people in the planet. Do we know how to prevent this? Yes. The answer, we know how to prevent 50% of all these cases and about the same proportion of death. How? Smoking cessation, roughly 20%. Alcohol, limiting or eliminating alcohol consumption between 4 and 80%, depend on the how much alcohol there is consumption in a country. Diet and use of sugary drinks, about 4%. Obesity, about 4% prevention of all cancers. Infections, about 10%, depending on the prevalence. Occupational risk factors, 4%. Solar exposure, UV radiation, 2% so far. We know 50%, if we would implement what we know today, data/information is there, we would save half. Why this is not happening?
But Lisa, what you just mentioned, that's also the same risk factors for cardiovascular disease and for dementia, isn't it?
Yeah. And diabetes.
And diabetes. But meanwhile, it seems we're always coming from the right, saying, I want to prevent my disease earlier. Who is going to help me? Because I have most of those risk factors and no one is, and whether I get one or the other of those diseases is just a lottery.
Yeah.
Any thoughts about how we come from the left?
Well, I think we go back to the primordial prevention. And to the politicians, there is an absolutely crucial need, for example, in tobacco prevention, to implement what we all sign, our country sign, the International Regulation on Tobacco Control, the FCTC. It's there. We know how to do it. What is missing is implementation, accountability, and follow-up. Same thing, sugary drinks, junk food, taxation works. It has been demonstrated. It works. And if you tax it, you can use those taxes to subsidize healthy foods, for example, fruits and vegetables, or to subsidize other parts of prevention.
Thank you. The urban community health worker, is that someone on a bicycle with a bag with drugs in?
If you can afford a bicycle, that is. So let me start by talking about, because the community health worker, urban or rural, and self-care, and all these things are related, actually. I think the first thing I want to say on the policy side is that politicians make policy for the next election, as has been said. Leaders make policy for the next generation. So how do you separate those two? Is by communities taking leadership, because politicians will always make policy for the next election. And I think the point by Ricardo about social accountability, taking things into your own hands. I'll give you an example. Right now, if you want to change the diet of the informal sector, we know that you cannot, because it is cheaper to eat junk food than to eat good food. Actually, energy-dense foods are more than 50% cheaper than good food. Now, that needs policy. Now, the politician will need to tax the unhealthy foods, and they will lose the next election. So, but communities can mobilize their own leaders using all the ABCD and all the way to X, if there are more alphabets that you can use, to ensure the right policy is done, because you are the leaders for the next generation. The politicians are only leading for the next election. Now, when it comes to self-care, the community health workers now start to link these two, because part of the big barriers for self-care in sub-Saharan Africa is structural violence. It's where you live. Now, if you're a woman who lives in Kibera slums in Nairobi, you live in one house in one room with your children and everyone else. Now, if you need to do your own pap smear, where do you do it? You can't, because everyone is around you. The next thing is water and sanitation. You are in this place where there is no clean water, no sanitation. Now, you need to do some basic hygiene you need to wash your hands with soap for self-care. So there are certain structural barriers for self-care that can be breached by community health workers, whether they are rural or urban. And what we are trying to do, and back into whether they are rural or urban, is to say, first, tool the community health workers with the knowledge and with the tools they need to support the communities. Now, those tools could be different between urban and rural areas. The tools of transport could be different. Even the numbers of households that you allocate to community health workers are different between whether they are serving a rural area. In a rural area, you may only get 50 households because each household is 20 kilometers away from each other. In an urban center, you can get 150 households because they are close to each other. So all those factors are considered. But at the end of the day, the question is, when the community health worker visits, there is also the regulatory framework. I'll tell you, in some countries, as a community health worker, you are not allowed to do a HIV test on the community because the laboratory network says you are inadequate. You've not been qualified to do laboratory tests. So there's also the environment that will enable the community health worker do their work, whether they are urban or rural. So it's environment, regulatory tools, and also tools for diagnosis, what they carry, BP machines and all these things. So tooling them within contexts and also giving them roles within context. So they are not a one-size-fits-all. Community health worker are just based on the community that you're living in. I think those are the points I really wanted to make. Thank you.
Brilliant. I think we have 10 minutes to go, so they'll be very short now. You have to be very efficient.
Thank you so much for this presentation. My question is an aspect of prevention for area of war. I'm coming from Yemen, which is a war area. So how can we implement prevention programs in area under urgent situation, which is a lot of injured people and amputation and all of this stuff? How can we implement the prevention programs? Thank you so much.
And your neighbor here.
Thank you. So last year I was in a congress around health communication, and one topic was fake news. And it was around an influencer in Spain who was posting a lot of information on social media that was true to her, but not really correct around what to eat and so on to be healthy. So what happened was a doctor saw this and tried to help her and say, if you were going to do this, let's make sure that it's the correct information that you're sending out. So to my question is, how do you see health literacy in the population in terms of precision prevention?
Health literacy. Oh, a lady in front here.
Hi, good afternoon. My name is Flor. I'm coming from Silker University of America. My question is, we talk about prevention, and I was born in Honduras. I know education is a big tool for prevention and implementing a healthy lifestyle, but how can we educate those that are not in schools? How can we use AI to teach or, teach the parents for a better lifestyle?
Lovely. And the final gentleman in black glasses here.
Thank you. I'm a man in black glasses. My name is Carlos. I'm coming from Portugal. And thank you, Ricardo, for predicting the pregnancy. Unfortunately, you didn't predict that I will get cold because of the open door. But anyway, my question is about, it's very nice that you introduced the vaccination in a non-communicable diseases session. And I would call it immunization. In the sense of promoting immune fitness. So I think this is a very important notion too, not only with the healthy lifestyles, with the quality of sleep, but also with immunization through life, and this is about aging population, this session also, to promote the robustness of immune system. Thank you.
Definitely. I hope you all got your shingles vaccine. It will stop you from getting all sorts of things. Will it not? So we will go through one last round now, and as you address some of this, maybe you'll also make your final statements, as it were. And I wanted to add my question, because I'm also a member here. I mean, Rhoda and Githinju, you both run universities, right? And someone put me in a dilemma last night. They said, what's your session about tomorrow? And I told them. And I said, but you're an academic. Do you teach your students this? So that's what they asked me, and I didn't know what to say. So that's my question I want to add to you university leaders. Githinju, do you want to start now?
Yes, our university, Amref International University, is all about primary health care, and we integrate, all these concepts into the curriculum, all of them, and we take our students to the field where we are doing malaria work, sanitation work, and we lead them for public health. So I'll hear from Rhoda, but I'm sure, having talked to Rhoda, this is very likely the same approach. I just want to give the question around health, fake news. I don't know how many of you here have had your own videos, like now I'm speaking to you and there's a video being taken, have been taken by people who do deepfake and then used the AI to change my voice to actually say, I have a new treatment for diabetes. I've had 4 of them, diabetes, arthritis, hypertension, and I don't... well, unfortunately, I haven't received any of that money, but people have bought the medicines. Yes, people call me and say, thank you very much. I just received the package. And I'm like, what package? Yeah. So this is a big challenge. And I think maybe the AI, we were discussing this and we're saying that AI must find a solution for AI problems. Because like stamping fake, there must be a solution AI can give us. Because these videos are being consumed by millions of people, and it's reversing the gains we've had on health literacy. So that's all I would say about that, but I'm sure there is a lot more that can be said around here. The question on school and education about how to educate those people who are not in school. I think in our own experience, school-based family education is a critical tool when you educate children about clean water, when you educate children about good food, when you educate children about sanitation. That information changes the behavior of the families that they come from. So I think in all this policy around using the school environment to improve health literacy at home, even for those who are illiterate, for us is a really powerful tool that we must integrate into our health prevention and promotion agenda.
Thank you. Elizabeth?
Thank you.
Thank you very much. I would like to address our colleague from Yemen. I don't see her anymore. Yeah, hello. Thank you very much for your question. It's such a challenge situation when you are in a war situation. There are all sorts of needs, but I think the driving line is that do whatever you can for that person / that community there and now. Try to help, even if the situation is very challenging. In war situations, it's I think the very minimum you can think about is vaccination. Vaccination, and eventually, if you diagnose infections, for example, hepatitis A or something like that, that's relatively easy to detect, even with very basic labs, that you act on it now. So that would be a suggestion. And then that at least the healthcare workers are aware of what we call the code against cancer, and I will give you information for our website that they are aware of that, because they will find these people in very different situations, being exposed sometimes to toxic environments, chemical substances used in war, unfortunately, which cause diseases, and of course all other risks. But be pragmatic. What can I do there and now for the person or the community within the situation until we wait for peace to arrive? And then I would just like to address Flor. Thank you, Flor, for your question on education and the role of education / fake news and how important is that. I think education is absolutely fundamental for behavior change and influencing political choice, but is one element out of a whole series of elements that influence behavior. Everyone knows smoking kills you, 20% of the human population smokes. So it's not only knowledge, it's beyond that, but knowledge is indeed the first step. And the community, the academic community, has the obligation of providing the right information and not disseminate news unless there is scientific base for that. With those words, I just wanted to invite everyone to continue this dialogue on the 19th to the 21st of May 2026 in Lyon, France. We are going to have a 3-day conference. First day, etiology of cancer. Second day, prevention of cancer. Third day, policy for cancer prevention. It's the celebration of the 60th anniversary of the International Agency for Research on Cancer of the World Health Organization. Please, I have several pamphlets here, and they have the barcode. Come and continue this dialogue specific on cancer with us next year.
Thank you. Ricardo, please.
So I'd like to start 1 minute, really. And I still have to leave time for you, so I'm going to be very quick. I've also had my fair share of products that I've not got any profits from. But it's the Wild West in many ways, and this is a problem. And you're absolutely right. That's why the governance of AI is a critical issue. I want to build up on what Elizabeth said to the colleague from Yemen. Having served at the beginning of the war as a medical volunteer in Ukraine, what I saw, and we're starting to see around the world, is many times funders focus a lot of their funding for the front line, but they forget that health systems need to continue to work in a country in conflict. And I think when we're talking about rethinking aid in global health, we also need to understand that supporting health systems to continue to work, to be able to provide critical aspects, as you were mentioning, on vaccination and so forth, is absolutely critical. On the question on social media and fake news, also to say that social media has a lot to blame here, but there are also good examples. If you go onto YouTube now on your phone and you search a health term, the first thing that will pop up are the first videos will appear associated as health-related sites. And these are sites that have been curated between WHO and YouTube to make sure that the first videos are actually from a trustworthy source. So there are actions that these major corporations have taken, but they have to do much more. And us as global health community, we need to push them in that direction because the negative impact of fake news is tremendous. On the educational piece, we're seeing examples of very interesting approaches of using technologies to reach people who are not in the educational system. Just one example, many people don't have a smartphone, but they do have a basic phone. So using basic SMS texting to ask questions and getting a response from a large language model that has been curated for educational purposes to reach the youth that are not accessing education in any other form is one example of how this can be done. And this is an area that really needs to be explored and where technology potentially can play a role. And finally, Professor Khobalkhordaid mentioned vaccination of adults. I think it's a very good example. Most policymakers, when they hear vaccines, they think of children. And it's a critical area where proactively we need to reach out and actually technology could help us identify them. So I guess that's the spirit of this room, is we need to use the technology and the knowledge we have to proactively reach out, to proactively incentivize prevention so that we can improve the health outcomes, so we can free the resources to treat those that will need the precision care that will be so expensive in the future.
Thank you. Rhoda, as the co-conspirator and co-organizer, close us out, please.
Okay, perhaps just to add on a comment related to the rich platforms and networks for people out of school. I think Ricardo has mentioned how you can creatively use technology, but we've also done quite a bit of research around this, and we know sometimes they struggle with text messaging and they prefer voice in their own language and many other issues. But also the social networks, we've done some work around there in terms of using social networks and providing correct information that can be used through multiple networks, in addition to the children, as Dr. Githinji has mentioned. And then there's also an area of how you frame the messaging. I think most of our messages have been framed in a threatening way, and increasingly we are realizing now that gain-based framing sometimes is better. And we probably need to study that. We are doing quite a bit in terms of teaching these concepts. I think what is missing is the research around these concepts, because the funding for research has been skewed away from some of these spaces, and probably we need to do more, because we have to research into what we teach. Otherwise, I think this has been excellent, moving us from the right to the left in terms of how we can use data and technology to be able to better characterize who is at risk of becoming ill, and being able to target them more than we have done previously, both at individual as well as community level, and how we can use this to advance the world. And if I must end with one comment, it's data, and let's make it available in terms of mapping the risks more and being able to speak for the data, and probably use the A, B, C, D, E, and I don't know if it's longer, so that we can speak for the data. Thank you so much, everyone, for the excellent contributions.
Can we have a group photo, please?
Please, if anyone wants the information, the cancer conference.